Welcome. My name is Elizabeth Tanner. I'm an associate professor at the Johns Hopkins University School of Nursing with a joint appointment in the School of Medicine, Division of Geriatric Medicine and Gerontology. The purpose of our talk today is using an interprofessional approach to dementia care. The objectives which we hope to accomplish include summarizing the benefits of using an interprofessional approach to dementia care, identify the key components of the collaborative process, and to describe the members of an interdisciplinary team, including roles and responsibilities. What are interdisciplinary teams? Think about that for a minute. Most of us are familiar with a multidisciplinary approach to care. However, interdisciplinary teams and an interdisciplinary approach has been recommended for some time by the Institute of Medicine as well as agencies which are responsible for quality and safety of patient care. Interdisciplinary teams are groups of allied healthcare professionals who work together collaboratively with close communication and coordination to optimize patient care. Each member of an interdisciplinary team brings a unique set of skills, knowledge, and experiences to support and augment the team. An interprofessional approach has been long identified as an ideal approach for delivering care with multiple benefits. For example, an interprofessional approach results in more effective coordination among team members. This coordination results in more effective assessment of patient care needs and enhanced problem solving in development of a plan of care. In other words, it's a more efficient approach for coordinating care and resources. This is often demonstrated by avoiding duplication of services, which many of us are familiar with. If a patient is seeing multiple individual healthcare providers, frequently each healthcare provider will order a test that is being repeated by someone else, which was ordered by someone else. So by offering a coordinated approach to care, we can avoid that duplication. We can avoid errors as well by coordinating care. And this leads to enhanced patient outcomes. It also leads to better transitions of care, which we know for older patients, and especially older patients with dementia, are very detrimental. I've provided you with a link here on this slide of an example of a poor transition of care which resulted from lack of coordination and lack of an interprofessional approach to care. Another benefit of interprofessional care is improved patient satisfaction. When all members of the healthcare team are talking to one another, coordinating, and focusing on the patient and caregiver, patients are much more satisfied. Another benefit actually is provider satisfaction. Studies have shown that when healthcare providers work as a member of a coordinated healthcare team, they too have an increased satisfaction. So what is this interprofessional approach? Well, we're used to creating our own specific plans of care within our own disciplines and implementing them in isolation of other members. It's not surprising that we utilize this approach because we're educated in silos and are not taught to collaborate or work with one another. So within the practice arena, we have a siloed approach to care, which might be compared to parallel play. To provide an interprofessional approach or collaborative approach to care really requires a culture change in geriatric dementia healthcare. There have been guidelines developed to assist us in approaches for providing interprofessional care. One example is a document called the Core Competencies for Interprofessional Collaborative Practice, which was published in 2011 by a panel of experts from 6 healthcare professions. Those professions included nursing, medicine, osteopathic medicine, dentistry, pharmacy, and public health. And I've provided you with the link to that actual document. The document is focused on 4 basic domains to interprofessional practice and competencies within each of those domains. The domains include shared values and ethics, roles and responsibilities, communication, and teamwork. And demonstrating competency across those 4 domains is essential to the interprofessional approach to care. Another guideline which is very useful to healthcare professionals in delivering interprofessional care is a document called, or an approach really, called Team Steps, which was developed by the Agency for Healthcare Research and Quality. And I've provided you with the Team Steps link as well. And this document includes many useful techniques for actually providing interprofessional care, such as common communication techniques. So next, let's talk about who needs an interdisciplinary team. Well, we know that patients with dementia typically have very complex medical, psychological, and social needs. And for that reason, teams are a much more effective and efficient way for assessing patient needs and creating a comprehensive plan of care. Approaching patients with dementia rather than in a collaborative team approach is clearly much more efficient than having each discipline working separately. Also, family caregivers benefit tremendously from an interprofessional approach to care. And family caregivers also need to be considered as part of the team in developing the plan. So what is interprofessional practice? Interprofessional practice involves multiple healthcare workers from different professional backgrounds who will come together and work collaboratively, focusing on the patient, families, caregivers to deliver the highest quality care. Interprofessional collaborative practice involves unique communication skills of active listening and problem solving, which takes place in a coordinated approach with all members of the team. It involves openness to new knowledge and really new approaches to care, and cooperation, coordination, and collaboration. I've summarized the collaborative approach to care in comparison to the dementia approach for a patient and family with dementia. For example, utilizing a collaborative approach would result in enhanced rapport and empathy, including concern for the caregiver as well as the care recipient. It would involve professional communication techniques, including active listening, providing comfort for both the patient and the caregiver, using affirming body language, and being open to input from the patient and family. Compared to a traditional approach, was a more directive approach where each separate healthcare discipline provides a plan of care which is really more directive, doesn't encourage input and conversation from the caregiver, does not involve open communication, and often involves use of technical language rather than lay terms which are understandable to the patient and family. The source for approaches to dementia care using interprofessional techniques is provided at the bottom of this slide. So you can take a look at that. Now let's look at some of the dementia-specific interprofessional competencies. I mentioned the 4 domains for interprofessional collaboration, and let's talk about those specifically in relation to the needs of the patient and family situation with dementia. So these competencies include describing the roles and responsibilities clearly to each member of the healthcare professional team, as well as the caregiver. This is essential in order to coordinate care among each of the various allied team members. It also involves recognizing and observing the constraints of competencies, roles, and responsibilities for one's own discipline. And in some ways, that should really evoke relief, because each of us coming from our own discipline does not need to be able to meet all of the patient's needs. We can recognize our own constraints and rely on others to fulfill the needs in areas that we can't. It also involves demonstrating respect and knowledge of the unique contributions and responsibilities and competence of members of the healthcare team, including the caregiver. Demonstrating respect means acknowledging the strengths, the values, and the goals that each member contributes, and that includes the caregiver. Another competency includes demonstrating knowledge of the continuum of professional and support services required for quality comprehensive care. This means recognizing that members across the healthcare team, including professionals, paraprofessionals, and other allied professionals, can bring valuable support services to the plan of care. Also, it involves effectively collaborating, and this is most important. Collaboration is really central to interprofessional care. Collaboration among all the members of the team, and I'll show a diagram in a minute which demonstrates that. And finally, demonstrating knowledge of when, where, and from whom dementia patients and family caregivers may obtain care and treatment. It's very important for us as the healthcare providers to be working together, coordinating, collaborating, cooperating, and making very clear the plan of care for patients and families who are dealing with dementia. Now, this diagram essentially demonstrates what I've just been talking about. As you can see, all members of the interprofessional team exist in circles of equal size surrounding the patient and the family. The patient and the family is at the center of interprofessional care. And each and every member of the team is providing services that meet the needs of that patient and family in cooperation with one another. I'm going to start with one example of a patient, Mrs. Smith, whom I'll call Mrs. Smith, who was living alone independently in the community, was followed by a geriatrician, and who provided her basic health care. The nurse who was working with that patient was responsible for, in the beginning, assisting her with her medications, communication, was knowledgeable about her medications, was a little bit involved in her coping strategies, but it was not until the patient's memory problems began to increase that she became more involved. She noticed that the patient did not keep several appointments with the geriatrician, and she called to try to find out how Mrs. Smith was doing. When Mrs. Smith did not answer, she attempted to contact a family member, a sister who was 80 years old and lived in the state of Arizona, and the sister expressed the same concern that she had not heard from her sister, Mrs. Smith. So what happened next was her sister, after not being able to reach her Mrs. Smith, called the management of the apartment complex, who went to the apartment and found Mrs. Smith in a state of confusion, unsure of where she was, what she was doing. Neighbors reported they had not seen her car move for about a week and had not seen any sign of her. They called 911 and she was taken to the emergency room. So oftentimes the workup for dementia begins in the office of a primary care physician who assesses cognitive function routinely, and as a patient begins to develop symptoms of cognitive decline, may either conduct an evaluation to determine, rule out other causes, determine the cause of cognitive decline. In this case, it was the geriatrician who was involved in the care. In this case, she was followed by the geriatrician, who is an expert in evaluation, diagnosis, and management of complex dementia patients, and has expertise in managing behavior and symptoms and comorbid conditions. So as Mrs. Smith was admitted to the hospital, the geriatrician, who had privileges at this hospital, worked with the team to evaluate Mrs. Smith's condition. Her situation was one in which she had experienced cognitive decline and had apparently become depressed and was not eating or drinking adequately. She was severely dehydrated and thus was admitted to the hospital. She had signs of malnutrition from not eating, and really had symptoms of delusion in association with her depression. So the medical team began to manage her condition, but at the same time, she was followed. The social worker became involved, and the social worker began assessing her home situation, the fact that she was living at home. She had no relatives living nearby in the state. She had one nephew who was living in about 2.5 hours away. And so the social worker began right away to try to coordinate the plan of care for Mrs. Smith, who was diagnosed with early to moderate Alzheimer's disease. So the social worker became involved in working with the healthcare team. The psychologist became involved in the healthcare team and was part of the healthcare team in deciding which neuropsychological assessments to perform, and also was involved in providing therapy to Mrs. Smith. The pharmacist was involved. The pharmacist played a very important role in this interprofessional team because not only was she being evaluated for her dementia, and the assessment involved considerations for medications that might delay the progression of her dementia, but also she was treated for an acute psychotic depression. And it took about 2 weeks to regulate medications to get that under control. And so the pharmacist was working in collaboration with the geriatrician, the nurse, the social worker, and in managing her plan of care. In this case, there was not a nurse practitioner involved, but a nurse practitioner could have been involved and was in fact involved later on when she was transferred to an assisted living facility. The nurse practitioner provided health care to her once she was stabilized and her health care was no longer complicated, and worked with her to coordinate her counseling and therapy, as well as medically manage her. She no longer was followed by the geriatrician, who did not have privileges at the assisted living facility where she was placed, and she could not travel to see the geriatrician. So a gerontological nurse practitioner actually followed her from that point on. Let's see who else was part of the team. Geriatric psychiatrist. The geriatric psychiatrist was really central to the team when she was first admitted, in working with the pharmacist and the geriatrician to medically manage her, to stabilize her, evaluate the comorbid conditions of depression and dementia in this case, and to monitor her, and coordinated care with the social worker, who then brought in the nephew who lived several hours away to discuss how they would transition her back to the community. Okay, that wasn't one example of a patient who included numerous members of the healthcare team, both in the acute phase and in the follow-up phase, as she was transitioned to an assisted living facility. She was later stabilized. Her original, her admitting MMSE score was 17. She improved dramatically as her dehydration was treated and her depression was treated, and her MMSE on admission to the assisted living facility was 22. So she was functioning much better at that point. She also needed physical therapy because she had become weakened and suffered deconditioning while being in the hospital. Now, the next patient I want to talk about is Mrs. Jones. Mrs. Jones was living with her daughter here in the center of our diagram, and she was functioning very well. She had mild cognitive impairment, but was still driving her car and doing some volunteer work. And the daughter felt very comfortable with Mrs. Jones going about her business during the day while the daughter worked. Mrs. Jones developed a urinary tract infection, which is not uncommon, and fell. She, although she did not hit her head or didn't report hitting her head, she was taken to the hospital. A CT scan was ordered, and head injury was ruled out. However, she did have significant bruising and an open laceration on her right ankle, which became infected and wasn't healing. So her urinary tract infection was treated within the hospital. And she had an uneventful course of antibiotic therapy. However, her laceration did not heal well, so she was discharged back to her daughter's home under the care of her primary care physician, who was following her, monitoring her medication therapy, and watching her cognitive status. Again, on admission, her MMSE was 18, and upon discharge, after a 5-day treatment, it was at a 23. And so she was functioning fairly well. But let's look at who all the members of the healthcare team who were involved. Well, first a social worker became involved because the daughter, who was the caregiver, was greatly concerned that her mother would no longer be able to stay by herself in the home while she worked. So the social worker's job was to develop a plan of care, look for resources to prepare for providing assistance should the daughter, should she be discharged and not be able to stay at home alone. They were unsure at the time during the hospitalization just exactly what her cognitive status had been and whether or not she was driving safely before she fell, and whether or not she'd be able to continue staying by herself. So the social worker became involved and worked with the daughter at that stage. The psychologist was not really needed in this case, so we'll skip that one. Let's go see who else is here on the team. The pharmacist was involved in coordinating not only the medications during the acute hospitalization for the urinary tract infection, and she had some delirium within the hospital, which is not at all unusual. It's very common, superimposed on dementia and with urinary tract infections. She was also started on medication to delay the progression of her cognitive impairment. Okay, let's take a look. Occupational therapy could have been involved, although in this case it was not needed. An occupational therapist with dementia care assesses functional performance and determines the type of assistance that might be needed or modifications that might be needed for the individual to safely complete activities of daily living. Okay, let's move on to the next member of the healthcare team. The chaplain. A chaplain is an important member of a healthcare team who provides visits and ministry to patients and family members of all faiths and beliefs. Should the caregiver express a need for this service, the chaplain would definitely be involved in the team. Okay, next, dietitian. In her case, a very in-depth history revealed that Mrs. Jones actually had not been eating well and had lost weight. And she, during the day, was not eating lunch, had been picking at her food during other meals which her daughter prepared. And so a dietitian worked with the daughter and Mrs. Jones to determine appropriate nutritional goals for her and food preferences, and she was still able to eat independently. Had she not been able to eat independently, the dietitian could have assisted the family in that area. Physical therapist. Again, she experienced functional decline while hospitalized. This is a very common result of hospitalization, particularly in patients with dementia. When they are placed on bed rest, they become weak very quickly and even lose muscle mass and need assistance in regaining strength and function. And the physical therapist was involved in assisting both the patient and the caregiver to maximize ADL function and mobility. The geriatric psychiatrist was not actually needed in this case, although she was assessed for depression, which is very common and should be assessed and ruled out in every patient who is diagnosed with dementia. Okay, next on the team, the family member of choice. Again, the family member is right here at the center of the team, and insight from them on the patient's routine, providing information by proxy, as well as their experience with caring for the patient is critically important. While not seen in every healthcare team, the physician assistant works under the supervision of a physician and is capable of recognizing change in cognitive function and ordering routine diagnostic tests and counseling with patients. And generally, the physician assistant then refers the patient if further follow-up care is needed. Okay, that concludes our approach to interprofessional care with patients and caregivers with dementia. So in summary, we've talked about the benefits of an interprofessional approach to care, which really is essential for patients with dementia. We've talked about the key components of the collaborative process and what the family and caregiver can expect, as well as what members of the healthcare team can expect. And we've discussed roles and responsibilities of members of an interdisciplinary team providing care for patients with dementia. And that concludes our talk.